thank you so much for joining us tonight. We have a great webinar, How to Uncover Your Potential Sleep Patients' Real Objections. This is something that we get asked all the time. I want to be doing more sleep cases, but I'm having some issues with getting patients to say yes, and have an amazing speaker with us, Michael Cowen, to discuss, why aren't patients moving forward? And one of the trickiest things is it's not always what you think it is. Michael is the CEO of Awaken to Sleep, and he has 20 years of sleep medicine industry experience. So he's been around, and I'll let you talk a little bit more just about your background, but he is a dental sleep medicine expert and coach. This is what he's doing day to day, is helping sleep practices level up their sleep business. And I love some of these pictures here. This on the top left, this was from our course that we just did in April, our dental sleep medicine growth course. Top right, there's Michael and Rose Nierman, who's also on with us. And the bottom right, what's going on there? You're stealing me.
I've signed waivers where I can't speak to that, so I don't know what to say.
Yeah. Well, it looks like there's a witness behind you, Mark Murphy.
Yep.
That's Michael, and then this is myself, John Nierman. I'm the president, as I mentioned, of Nierman Practice Management. 16 years of dental sleep medicine industry experience, and we specialize in CE systems and medical billing. So what we do is help dental practices get trained, get paid, and grow. And there's me and my twin on the bottom right that you were trying to steal. I think we recovered them. But so that was from the AADSM. It was my birthday in May.
Little fun.
Absolutely. So yeah, and speaking of that growth course, so we did this one in April. It was fantastic. We'll talk about it at the end. But let's talk about.
Those are all the incriminating photos, man.
I had to do it. I had to get you back from that course for what you did to me. So
okay,
during the script session. So yeah, we'll talk about that too, I'm sure, at the end. But what we're going to talk about today is, why aren't your sleep patients moving forward? We're really going to dive into that and how to really build trust and rapport. That's going to be a key part of identifying the hidden concerns and objections that your patients may have. Then we're going to talk about addressing those most common concerns and wrap it up with some final thoughts and Q&A. So, what problem needs solving? Why are we here tonight? It's the need of wanting to get more patients and having those challenges with case acceptance. That's what it comes down to. A lot of practices, they're spending money on marketing, they're spending time and energy and resources to get these patients in the door. And a lot of these patients just aren't moving forward. So what can we do about that?
Yeah. Hey, John, before we move on from that, can we just poll the audience real quick?
Yes.
You guys, there's enough of you here. You're going to have some similar things, but if you could put in the chat, if there's
an actual poll.
Oh, you have an actual poll? All right, I'll stay quiet. I'll do what I'm told.
That was good because you reminded me. Okay, so we have 2 questions to start, and this is great. This will give us a really good sense of where everyone's at. So if you could go ahead and answer the 2 questions here. Number 1, how many sleep patients are you treating per month currently? 0 to 2, 3 to 5, 6 to 15, or more than 15 a month? The second question is, how many sleep patients would you like to treat per month? And it's the same answer, 0 to 2, 3 to 5, 6 to 15, or 15 plus. All right, Michael. Okay, perfect.
Yep.
So with number 1, it looks like 50% are doing between 0 and 2 a month, and then another 20% are doing 3 and 5 a month. So about 73% are doing anywhere from 0 to 5 a month. And then we have the other, 25% doing more than 6 cases a month. but only 2 or 13% are doing 15, more than 15 cases a month. Now let's look at the second question. How many sleep patients would you like to treat per month? We're seeing 67% would like to treat more than 15 patients a month. All right, let's talk about why do sleep patients move forward in the first place? And I'm sure you all can talk about this too. Well, what are the successes that you're seeing? What seems to trigger that behavior that they just move forward right away, or there's no resistance? They want improvement. That's why we all make any type of buying decision. We want a better future self, a better future situation or scenario. They want to resolve pain points. But in order for them to move forward, especially in healthcare, they have to have that trust. That trust has to be there. Michael, anything to add to that? I'll take that as a no. All right. I didn't see it on the screen.
Oh, yeah, no, my mic was muted. My apologies. First time I've ever done this. Yeah, the only thing I would add is that last line of trusting the solution and the provider. People like to buy from people they like. So becoming a liked provider by these patients, as you're building, we're going to go into a lot of building trust a little bit later tonight, but being a likable provider actually does matter. So that helps with, them trusting you and liking the solution that you're offering.
Yeah, absolutely. All right. So now let's talk about why patients don't move forward. What it comes down to is fear. Fear of something. That's why they're not moving forward, especially if they meet all the criteria. They're qualified patients. They're going untreated. So let's talk about the different types of fear. So fear of making the wrong choice. I'm sure we've all felt this when it comes to a buying decision, and it can be big or small.
Right.
Fear of financial risk. I mean, this is quite common, right? It's an investment. So are you going to get a return on your investment? What's the value that you're getting? And if there's uncertainty there, so yeah. Anything to add while we're discussing these specific fear points?
Yeah, I think that it bears noting that as the financial dollar amount increases, the buyer's fear of making the wrong decision proportionately increases. So when less than $5 is a commodity sale in buyer psychology. That's why everything at the gas station counter, if you ever walk in, from bananas to sunglasses to packs of gum, 5-Hour Energy, it's less than $5 because it's an impulse buy. But as that price tag goes up, it's a much different decision paying for a filling versus paying for a sleep appliance versus paying for a full mouth rehab. Those two fears are going to go hand in hand together as the price increases.
Absolutely. All right, this is another big one, fear of change. This is, I think, a bigger one than most people realize. We get comfortable with our current situations, and it takes inertia to make a change in your life, even if it's a positive change. Fear of the unknown, and this can manifest in many different forms. If it's not quite clear what could happen or what couldn't happen, then there's going to be that resistance.
Yep. Yeah, change and the unknown are those two things coupled together as well, right? If you require somebody to do something, they're afraid of change because change typically requires them to go into the unknown, or vice versa. If it's something they don't know much about, they walk in, they're scared of this, their spouse has the issue, but this isn't really like their main concern. They're afraid that they're going to find out more. That's why there's a resistance to testing in the first place. I don't want to know. How many family members, people, friends, conference attendees have we had that conversation with? Now you have it or you don't. The test doesn't make you have it any more than you already have it. But there's a weird psychology behind that. And it absolutely is a fear for a lot of patients.
Yeah. And we know this too. People will not buy if fear exists. And we deal with this in every industry. This exists.
Yep.
But without trust, they won't tell you why. And this is the whole crux of this webinar tonight, really diving into this dynamic here. How many times have you seen this on the outside? Yeah, everything looks good, just need to think about it. Right? But what's really happening on the inside? What's the internal dialogue going on, right? All the fears, all the doubts, all the what ifs, and second guessing.
Yeah, I mean, we're going to get into building trust a lot here, but if we can't accomplish that first step, we're just not going to know why they say no. So we're going to have this weird unknown gut feeling that something's off, but we don't know what, and that's not something that we can measure. So this is absolutely the first hurdle that we got to overcome.
Certainly. So let's talk about it. Let's talk about trust, authority, predictability, and empathy. Let's start with authority. Number one, I think this is the absolute biggest one, is patient education. Making sure that you and your team are really informed and trained in dental sleep medicine so that you can have these conversations with the patient on what can they expect, what is the process, what are the dynamics involved. If they're asking you questions, being able to answer their question. Anything to add on patient education?
Be authentic, not close the gap in your education. You can be the authority source and not use 5-syllable words. So make sure that the education is digestible for your patients.
Have a separate sleep brand. This is definitely an easy thing that you can do that can make a big impact into the perception of you as the authority in dental sleep medicine. Just the perception alone makes a big difference, and it shows that you're committed to this space. It shows that you've invested the time and the resources to establish a brand, and this is how you see yourself. You're a sleep dentist, you're a sleep practice, you're an airway practice. Patients will see you as that too.
Yeah, and I would also say there's a balance here. If you guys are on here and you don't have a separate sleep brand, but you've got a page on your dental site and you're focused on your internal patients, that's going to be okay for now. You're starting to check a box. But the second that you start marketing to physicians, marketing external directly to consumers, that's going to be point critical, like what John said, to have a separate brand that patients can identify automatically as an expert. If you're a member of the AADSM or a diplomat of the AADSM, having that on your site, having your name on the door, things like that add that validity. Those are going to be crucial for external referrals.
Yep, absolutely. So the next one is, utilize technology. So you can do some really cool things with CBCT, for instance, where you can get an airway view. And this is not for diagnosis purposes. It's for visualization. It's for patient education purposes. It can really help for them to kind of connect the dots. Most people, they've never seen what an airway even looks like. And continuing education, this goes along with patient education, but also just your own confidence. And there's a lot of different elements to dental sleep medicine. It's a journey. It's never just taking one course. And I think the most successful sleep practices are the ones that are always at the continuing education courses. They have that open mind, always learning mindset, and that takes them very, very far. And along with that, getting your team members trained, getting your team members to really buy in. They're going to have so many touch points with the patients, more than you as the dentist, that it's crucial for them to also have these same components down. Patients building trust with your team.
One thing on the technology, just as a quick note, you guys, if you have the technology and you use it, tell the patients about it. If you have an intraoral scanner and this is what you use, your team is likely doing all of that work. Make sure that they have a talk track or a specific set of verbiage that could be even very short, that tells the patient, hey, you know what, doctor has invested in this technology where this camera actually takes thousands of tiny pictures of your teeth, and we can bioidentically match this appliance to your teeth and your bite because of this cool technology, like talking up the technology. And when you're not in the room, giving you credit for investing in that tech for the comfort of your patients. Make sure that talk track brings it home to the patient benefit, not just how cool the technology is.
All right, predictability. So this ties in with the fear of unknown and with the patient education. So if patients aren't really sure what the process is, they're going to have this anxiety. What's that next step? What's going to happen? They have all these questions. And if the more that you can drive that conversation on, here's the steps, let's talk about the process here. As you're educating them, give them a very simplified step-by-step, how we can build a treatment plan that's going to help you achieve your dream outcome.
Mm-hmm.
And the more that you can just make it predictable for them, the less anxiety they're going to feel in every aspect of this journey.
Yeah. And John, I think you hit a good point there. In that communication, we always have to bring it back to their outcome. Just like the technology statement can't be well, doctors invested so much money in this really cool tech. That's why he's charging me money for this. It's got to come back to their benefit. So it's what you said, this predictable pattern of here's what we do, here's where we start, here's what's next, here's your dream outcome. Like always being able to tie it back to that third bullet there. Otherwise, the patient's just wondering, when do I actually receive this benefit?
Yep. All right. Oh, I love this one. So let's talk a little bit about empathy. This question actually came up at our course this past weekend. We had a TMJ and airway cadaver course. And this came up because this is a big one for TMD patients and orificial pain patients too. And the question came up, what's the difference between empathy and sympathy? And I think we've all heard this before, but it still can get muddled because it is quite similar, but there is a big difference. And so what that difference is empathy is the ability to understand feelings and emotions of another person. And sympathy is feeling compassion or pity for someone else's suffering. For empathy, I can only imagine how frustrating that must feel to not be able to spend more time with your grandkids. Versus sympathy, and in this example, you have a potential patient who's saying that she just doesn't have the energy to spend as much time with her grandkids on the weekends or at night. She can only pick them up from school and then she's tired and she can't do what she really wants, right?
Yeah.
So with sympathy, I'm sorry to hear that you aren't able to spend more time with your grandkids. I'm sorry to hear that. Versus, I can only imagine how frustrating that must feel.
Yeah.
And this example came
from Ruth. Yeah.
Yes.
Our actual patient with Dr. Gilbert. Yeah.
Yep.
Yeah, absolutely. I mean, John, I mean, it looks, attendees, friends in the DSM space, this looks like we are splitting hairs to create a slide on a PowerPoint. Let's be real. I mean, in the plain English language, that's how it sounds. But imagine you're the patient. Like as we're going through all of this stuff, the building trust and all of this, if you can try to flip the perspective and you're the patient or you're the buyer, you're the consumer, whatever thing helps for you and the perspective. When someone says what John just did about, I can only imagine how frustrating that is, you're sitting in it with them. What you're doing verbally is you are turning to have their perspective instead of looking from yours and saying, I'm sorry, that sucks for you. That's a worse translation of what he just said. But that is the key difference, is you're flipping it to take their perspective. And when they hear that, they feel that you are their advocate. You understand them and they can start to put their trust in you.
And so let's talk about active listening. This is all connected here. So as you're having these conversations, you're applying these active listening skills so you can really understand what are their main concerns, what is their dream outcome, what's preventing them from achieving their dream outcome. As Michael mentioned at the very beginning, people are going to do business from people that they like, right? And so you can use some mirroring techniques to just subconsciously get people to like you more because people like people that are similar to themselves, that have similar interests, that are like-minded. You can mirror someone's tone, their body language. If they're coming in and they're kind of down, but you're like up here, you're up here and they're kind of down here, right? Are you getting closer to rapport? Probably not, too dissimilar. So that's the concept. But so if they're down here, if they're coming in, they're just like, man, I just had a really rough day, long day at work, and then, got a flat tire and I come here. And if you come in, you just, I get it. So that's the concept of mirroring. It can really help to initially, get into rapport right away. And then you repeat the last 1 to 3 words as a question. They'll kind of repeat themselves in a different way and start talking more and more. And people, they want to talk about themselves. They want to talk about what's going on. And so that's a nice trick to get them to continue talking and to build rapport as well.
Yeah. It's like on your last slide, the sympathy versus empathy piece. If Ruth, the patient, the grandma who picks up her grandkids, is tired when she gets them from school, saying something like, hey, how often do you feel too tired to pick them up and take them home? How frequently is that bothering you? So you've repeated their words and asked this probing question that John's talking about. Yeah. So you're not like, oh, I can only imagine how frustrating that is. When you pick your grandkids up from, if we start sounding like the, grade school English thing that my kids fill out, their textbooks, that it's going to break. It does have to be natural to what he was saying. But that's those probing questions and the extra words that they have said, repeating that is incredibly valuable.
It can be anything. So if they say, I'm just feeling tired all day, you can just say all day. And then they'll say, well, yeah. So all last week, every single day, by 4 o'clock, I was just done.
And pace. I don't know if we have another spot for this, but the speed in which you talk absolutely matters. I know if you're running, hopping from op to op, and your patient's sitting there and they're kind of down about their flat tire and their crappy day, and you're like, hey, how's it going? I just had my 4th shot of coffee and like shorten the gap. The tone, the body language, the pace, everything that you're doing, as much as it can mirror them and then be that uplifting for them, they're going to remember how you made them feel, even if they don't remember what you say exactly.
The handling these concerns, this doesn't happen at the very end where it's like, all right, now let's bring up your list here and let's go through it all. This should ideally be happening throughout the conversations where you're preemptively addressing what their concerns may be. So by the end of it, they might not even have any, or maybe they just have one that can be easily overcome.
And if you're not doing this perfectly, and people do bring objections in that consult, please make sure to write them down and discuss it with your team and find out where you can inject it earlier into those conversations before the patient gets to that spot. So if you've got it now and you've got objections at the end of this one consult, make sure you're documenting that and you're training yourself. Your patients, those no's are helping you train yourself to get to yeses, because you're helping pull that objection and handle it earlier before it comes up with the patient.
Yes. So how are we going to uncover their real concerns? Let's assume now that we've built trust and rapport. We're like this at this stage of the conversation or their, the journey here. Number one, labeling. I really like this. Michael, you do this really well. You talk about this really well with your clients. So I want to spend a little bit of time on that. And it's all kind of connected here with the other bullet points, asking questions, being candid, and articulating what's in their head. But again, we must have trust and rapport at this point.
When you're talking to your patients, there's some folks that you know really well. They've been in the practice 10, 15, 20 years. You don't need to spend all of this time building trust and rapport because you've spent a decade and a half doing that. But if we're talking about a brand new patient that was referred to you by a medical colleague who's never met you, who saw your sleep website and they filled out their form because your office person sent them a link and they filled out their health history, this conversation is going to be crucial. So as John's talking about this, you've got to put this in the frame of reference of which patient are you talking to? Half of you all that are attending this, I know by first name, and I could high five you if we saw each other at a conference. Like, Jeff, if I'm in your practice and we've known each other for 15 years, we're going to goof around when you walk in the room. You're just being authentic. But if I'm a brand new patient and I come in with major concerns, you're going to sit with me in that. You're going to do that shoulder to shoulder communication that we were talking about before and help me understand how much you care, because then I'm going to care what you're going to tell me. Until I know that you care for me and you've heard me and you listened to me, and through those labeling, repeating the words, labeling my emotions, connecting with me as a person, when I feel heard, you can talk to me about fixing my hurt. And that's the key. So knowing who you're talking to, if you guys are struggling with that, some of it is, are you struggling with new patients who are coming in from the cold? Or are you struggling talking to patients that have been trusting you for 15 years and you don't know how to bring this up? Those are two totally different conversations. But that labeling part of this, that emotion labeling, repeating their words, asking the probing questions, and just taking the time to be authentic and truly listen to them is going to be crucial.
Can you define what labeling is?
Yeah. When someone says, like, we'll use the Ruth example that we were talking about, the grandkids tired picking up her grandkids from school. Helping her label that emotion when she hasn't done that yet is what we're talking about. In John's example, a couple of slides ago, it said, that sounds like it's very frustrating. Is that what almost, I can only imagine how frustrating that must feel. That frustration, the word frustrating is you labeling that emotion. Every once in a while, you're going to get it wrong. Well, I'm not frustrated with that. I just feel terrible. Okay, well, you know what? I'm sorry. That does sound really terrible. How often do it's not repeating to sound like a robot. You're repeating for the deliberate purpose of building their trust. And you're not trying to manipulate them. You're genuinely sitting there to help this person, but they don't know you yet. And you've got to show that in every way possible from the very get-go. So that labeling is what John's specifically getting to here with the emotion is find out what hurts and help them label it with an emotional word. If it isn't frustrated, maybe like my example, when I had apnea, I would come home from work exhausted. I'd want to play with my kids. I'm the dad that does bedtime routine. That's my jam. And I feel like a total failure when I'm falling asleep trying to tuck my kids in at night for bed. They're like, Dad, you're snoring. That's not everybody's jam, but that's my story. So connecting with me on that is, hey, you love your kids a whole bunch and this is what you do. That sounds like it's really hard for you. Hard's a good word for that for me, right? You don't want to call me a failure. That would probably be a bad labeling word. But that connection, helping them define the emotional word that attaches to their pain is the thing that's going to help them feel the most understood. That is kind of the hallmark section of DSM, but people still give greeting cards today that are outrageously priced for a reason, because it puts words and heart to something that is emotional for them. So the more you can do that in this conversation, the better it's going to be.
Well said. And I'd like to add that starting it with, it sounds like, is a really great way. If you do get it wrong, you're not saying this is what you're feeling. You're reaching out. You're saying, right, that's what it sounds like. It sounds to me like you're frustrated.
And then, John, I love that, starting the sentence that way. It sounds like ... And then if they're not aggressive is not the right word, a verbally confident person, like in conversation, there's some patients that are extroverts and they're outgoing, they're just going to talk when you pause. Other people need the prompt. If they need the prompt, ask them, does that sound right? So when you make a statement, you're asking the question back, does that sound right? It gives them permission to correct you very easily, very passively. So they're not being aggressive. They're just saying, they're clarifying because you asked them to do that. Yeah. And John, you have be candid up there. The more authentic and the more candid and direct, kind and candid that you can be, man, your patients are going to start to open up. If you come in hot and heavy and you're super confident and this is what you have and this is what we're doing and this is how it works, that's authentic and direct. Maybe it's candid, but it's not the kindness. It's not the pulling them in. You've got to be a magnet that pulls them in. That's got to be a component of this conversation in that candor. So it's got to be the candor and compassion, the kindness, along with the confidence. All of those things meld together where you become the person that they want to buy from. You become the doctor that they want to be treated by. That's what you want.
Love it. Most sleep patients that don't move forward with you remain untreated. And that's why this topic is so important. Because most people that don't move forward with you are not going to a sleep dentist across the city. They're not going to be wearing their CPAP again. They're doing nothing. Why are they doing nothing? Let's talk about it. Mm-hmm. There's two types of no decision patients. So there's the status quo and there's indecision. So status quo, what that means is that they're kind of okay with where they're at. They don't want to change. There's nothing that's really, driving them to change. And then there's the indecision. These people, they're scared to change. They kind of know they need to change, but there's a fear there. When it comes to the status quo, so action occurs when the pain of the same is greater than the pain of change. So the pain of the same, how do you get that perception of the pain of where they're at to be at the forefront? And that's what you have to do when it comes to these status quo patients. You have to create a sense of urgency. And then this goes back to the labeling and, circle back and say, okay, if they're status quo, they haven't connected the emotions to what's going on. They're so used to it. They haven't thought about what are the real consequences here? How is it really impacting my life? What does that mean to me?
Yeah. Perfect non-dental sleep medicine example is vehicles. When you're growing up, you have your first car or your third car. It doesn't matter. It was a hand-me-down. You bought it used, whatever. And you don't have a lot of money and you've got a tight budget. You drive that sucker until either your status is affected because of your peer group, or it keeps breaking down so much, not changing becomes more painful than swallowing the car payment. So you change. And this is no different. It's just the same example. But that's they don't do anything because status quo. Being the same is more comfortable than changing. Someone who's, dating around and is terrified that this is going to hamper their romantic life, when they figure out that snoring is less sexy than a mouthpiece, that becomes the thing that will make them change. So,
great dental sleep medicine example.
Just in case the vehicle one didn't hit.
Right, that's right. So let's talk about the other type of the no decision. Indecision is they know they need to change, but there's a fear of change. So with this one, if you're attacking it with that, trying to create value and a sense of urgency, it's not going to do anything for these types of people because they already know they need it. So if you're showing them, case studies and talking about how beneficial it's going to be for them, it's really not going to do anything. And these people are still going to be afraid to change. If you hear those signals, I know I need this. I do plan on getting it. I've been so busy and this and that, but I do know I need to do this. You have to take on that more of a authoritative provider. They want to be told what they should do. Can get you in next week. This step will make it easy for you. And it's done. How does that sound? So you give them that very clear direction.
Yeah. And I'd say, and maybe a slight tangent or like a part B to that, because some of these folks are going to respond exactly to that. They just need to hear the validation that this is easy, the path, a clear, here are all of your next steps. The path is simple. I'm going to walk through it with you. They just need that level of confidence, John, just like what you said. And then every once in a while, you're going to have some people that they just need to reaffirm their trust in you. I mean, guys, especially if this is a longtime patient who you've built rapport and trust with over many years, this is a little harder to do with a newly referred patient. But if this is an internal patient that you've screened or they're coming to you after a lot of built trust, being able to step into that and say, hey, is there anything that I've shared with you that you're concerned isn't in your best interest? Do you trust me as your doctor? Do you believe that I have your best interest in mind? And going back to the foundation of that relationship and then building from there. And then saying, hey, listen, if you were my brother, if you were my mom, if you were my sister, this is how I would treat you. I think that this absolutely, whatever that pain point is and their dream outcome, again, always tying it back to that. You, Ruth, picking your grandkids up with enough energy to take them home, take them to ice cream, take them to the park. Man, we've only got today, and that matters to me. So this is my plan for you, but I need your permission for us to do that. Like stepping into that authoritative role, like what John said, not everybody resonates with that. But if you have someone who's struggling with indecision, remind them why they trust you, remind them how much you care about their outcome, and then ask for their permission to move forward in that vein.
Yeah, that's perfect. It is time for our next poll. So first question, what is your biggest hurdle to getting more patients? So, is it, do you need more outside leads, marketing leads, more physician referrals? Are you lacking physician referrals? Are you lacking a screening protocol, or your dental patients, your existing dental patients, are they aware that you're even treating sleep apnea? Do you have enough collateral, your questionnaires in your office? Or are you doing all those things and it's really, it's the case acceptance? Where are you at? And second question here, what is your most common or difficult objection? So what are you getting the most? Is it price? Are patients telling you it's just it's too expensive? Or, wow, this is a lot, I need to really think about it because of the cost? Or is it, do they just need to think about it? It's not necessarily a price thing, but they're not making a decision there. They need more time. Is it because they might be skeptical of the results? They just haven't bought in yet. Do they need to discuss with their spouse, or you're not sure? All right, looks like most of the answers are in. We're going to go ahead and give 5 more seconds and close the poll here. Perfect. All right, let's see what we got. So with question 1, what is your biggest hurdle getting more patients? 71% said they need more physician referral. This is also connected to what we're talking about today, because this, building trust, building authority. And so when it comes to referral building, that's something also that we at Nierman Practice Management really specialize in, that communication and correspondence. So if you did select physician referrals, come talk to me later. We can help you with that. That case acceptance itself is a big one. So 53% said that is their biggest hurdle to getting more patients moving forward.
Yeah. John, let me, if I may, just speak to the physician referral piece. What you've heard tonight could be perfectly replicated in a peer-to-peer conversation with your physician colleagues. They have pain. It's not their personal pain, it's their professional one. They only have a hammer, and these patients keep coming back, and they don't they don't hammer in well because they don't like CPAP and they don't have another option. So you don't have to fix all their problems, but understanding what they are, speaking to that, being authentic, and being a confident colleague that they can refer patients to in whatever category you're defining, that's incredibly helpful. The other thing that I heard Anju Ely say at our last growth course that was so true, but she said it so perfectly. She's like, I didn't start talking to physicians until a couple years after I kept pounding them with all these clinical notes, because I do my chart notes in Dental Writer Plus, and then she auto e-faxes them to all of these providers. So her intake lists every single doctor that patient has seen, primary care and specialist. Those go into her directory, and she's just sending clinical chart notes that are clinically appropriate to those doctors so that her name is known. You start building clinical credibility before you ever have a conversation. So, sorry, John, I know that wasn't your main tact here, but that is everybody's top, most people's top thing. Use your software, send clinical notes, and then go have this type of conversation with those folks.
Absolutely. With Dental Writer, I mean, you can just make it systematic. It's just a part of your protocol, every single case.
Yeah.
All right. And number 2, this is great. What is your most common objection? And 76% selected price. Usually with price, they have the money. So it's not really that it's the price. It's just the value is not outweighing the price.
Yeah.
And why isn't the value built up? Because we haven't tied the value to what their dream outcome is, what their pain points are. And they're not telling us that if we haven't built that trust.
Yep. And to anyone who's on here that feels like this is selling or this is hard because we're manipulating patients or we're trying to learn these verbiage techniques to talk to people in a different way, you only have 2 options when price is your number 1 issue. You reduce your price or you increase the value. We'd rather increase the value because your patients desperately need this care. And like what John said, they're often using that as the excuse for a lack of connection or value somewhere else. So we're just trying to make sure that all those points connect so that anybody who actually says price, it's because of the dollars they don't have, not because of the value that we haven't communicated. That's the crucial component.
Wonderful.
That's great polls, man.
With communication. And Anju Ely, Dr. Ely is going to be there. And she, I think about 33% of her practice is sleep now. And she has some great sessions on how she got her team on board and how they're doing a majority of, they're driving the sleep part. She's got some really great sessions on screening. We have many other speakers. Here's our speaker list as well and our topics. So we'd love to see you there. It's going to be a great course. And, we're all very passionate about this because, again, when it comes down to it, the patients that are not moving forward, most of them are remaining untreated. This is why this topic specifically is so powerful.
Yeah.
It's not just growing your practice, it's helping more patients because we know that's what they need and it's just not connecting to them. So
Yeah.
that's what we'll be diving into. Thank you all so much for joining us. Really appreciate it. Hope you all have a great rest of your evening, great rest of your week. Thank you, Michael. It was an absolute pleasure doing this with you, as always.
Always fun, man. Always a blast.
Yep, great time.
Yep.
Any
Thank
final
you.
words?
Yeah, I would just encourage everybody that's still on, keep doing good work. If you're struggling, come to the course, hang out with us. We're in 2 days, we're going to talk about everything that you need to be doing to grow your practice, one step at a time. But if you're happy with where you're at, if you're just trying to incrementally get better, we're here to help. I mean, reach out. Nierman's a great resource between software, tools, clinical communication. Reach out. We're better together, guys. The 1+1 is greater in this market because you can help so many people. We got to help more folks. So let's do it together. If we can help, we're here. Otherwise, thanks for having me, John. It is absolutely a pleasure. I always have a blast doing this stuff with you guys.
Likewise. Better together, right?
Yeah.
Awesome. Well, thank you all. Have a great night. and we'll see you next time.
Cool. Have a good night.
Bye, everyone.